Hello guys, good morning everyone. So are we ready for the glaucoma questions discussion? So we had the glaucoma quiz yesterday at 6 p.m. on the Telegram group, and here we are to discuss the questions. So shall we start? So the first question is supposedly like an anatomy or a physiology question, but it has a lot of practical relevance. Good morning, Vinod. Good morning. So the question is maximum resistance to aqueous outflow is at. Now, why is this concept even important? See, the resistance to aqueous outflow is what generates the intraocular pressure, IOP. So when the aqueous is trying to leave the eye, good morning Akash, good morning. So when it's trying to leave the eye, it encounters a resistance. Yes, so that gives rise to our intraocular pressure. And what is the normal IOP? 10 to 21 millimeter mercury. That is a normal range. Okay. Now, where is it maximum? So, in the trabecular meshwork, because trabecular meshwork is made up of holes. Okay. Beams and columns of the collagen. So, you have holes. So, where is the hole smallest in the trabecular meshwork? So, it is the juxtacanalicular portion. So, closer to the canaliculi. So, even, I'm not talking about the lacrimal canaliculi. So, in the aqueous drainage pathway, we have small canals, collector canals and canaliculi. So, juxtacanalicular area is where the pores are smallest, so the resistance is maximum. Good morning, BU. Now, why is this again important? That is the concept of trabeculectomy. So, when you are excising a 1 clock hour of trabecular meshwork during trabeculectomy, this chunk is what you are removing. So, that resistance is taken away. So, the aqueous can flow out easily. Is that clear? So, where is the maximum resistance to aqueous outflow? At the juxtacanalicular portion of trabecular meshwork. Is that clear? Okay, so we'll move on to the next question. Ocular hypertension increases the risk of OHT, ocular hypertension. Now, what is ocular hypertension? It's just increased pressure, hypertension, nothing to do with blood pressure. Okay, only the eye pressure, the intraocular pressure is increased. Yes, there are no changes or damages suggestive of glaucoma or that which define glaucoma. So what defines glaucoma? You should have optic disc changes, characteristic optic disc changes. You should have characteristic glaucomatous field defects. You should have RNFL, retinal nerve fiber layer thinning. Yes, none of these are found in ocular hypertension. Just the intraocular pressure is high. Yes, just the intraocular pressure is high. BU, it's very stiff. I'm just doing a little bit of icing, that only that helps. I can't take medication. So that's the point. All right. So I'm tolerating the pain, but it's kind of stiff and I don't want to give unnecessary jerks to my neck. All right. Now coming back to your ocular hypertension. Thank you so much for your thoughtfulness. Yeah. All right. So coming back to our ocular hypertension. So that is a definition of ocular hypertension. Yes, only the intraocular pressure is high. But still, although there are no glaucomatous changes, you have to reduce the intraocular pressure. Okay, you have to reduce the IOP in OHT, ocular hypertension, because there is a chance of it progressing to primary open angle glaucoma. Okay, now let's see the options. What exactly is it asking? Am I looking for primary open angle glaucoma? Yeah, kind of. But primary open angle glaucoma is not in the option. Central retinal artery occlusion, central retinal vein occlusion, keratoconus, ARMD. Okay, so it it's very strange. So it gives it is a risk factor for CRVO. Okay, especially in younger individuals. In younger individuals, when you have a high intraocular pressure, always be forewarned about CRVO. Yes, it could be a risk factor. Is that clear? And also, if you see CRVO in a young patient, always check their IOP. Again, it may not necessarily be a neovascular glaucoma. just be ocular hypertension. Is that clear? So ocular hypertension is a risk factor for CRVO. Please note it down. Next question. Double angulation of retinal vessel at the disc is called. So we are basically describing one of the optic disc changes of glaucoma. There is a double angulation. So there is a sharp bending. There's a double angulation of the vessel, disc vessel. What is that sign called? Very good, Vinod. Yes, it is bayoneting sign. So bayoneting sign is a sign of glaucoma. Very good, BU. So basically we're describing bayoneting sign. Bonnet sign, option A. Bonnet sign is an AV crossing sign which you see in hypertensive retinopathy. Okay, the distal banking of veins. The distal banking of veins is called Bonnet sign, and that is seen in hypertensive retinopathy. What about option B, bean pot cupping? Yes, we do see bean pot cupping in glaucoma, but that is not the double angulation of the retinal vessel at the rim. Isn't rule. What is isn't rule? Isn't rule is something that describes the normal optic disc ka neuroretinal rim thickness or the width. Yes, wherein when you look at the optic disc, the neuroretinal rim is thickest or widest inferiorly. It is thinnest temporally. Okay, so widest inferiorly followed by superior rim, then the nasal rim and least temporal rim. That is isn't rule, and that is normal. Okay, describes normal. BU, just remind me when we do the next retina vitreous discussion, I will discuss this distal banking sign. Okay, so today we will stick to glaucoma. The earliest visually significant visual field defect in glaucoma. Okay, so this is like a one-liner kind of. See, when you talk about glaucomatous changes, the earliest is isopter contraction. Okay, isopter shrinking, but that is visually insignificant. It doesn't hurt the patient at all. Patient is not even aware of it. Okay, but what is visually significant? It's a paracentral scotoma. It's a non-seeing area around the fixation, around the center. So do we have any option like that? Arcuate scotoma. Yes, arcuate scotoma is seen in glaucoma, but that is not the earliest. Ring scotoma, it comes even after arcuate scotoma in the progression. Nasal step you can get initially also. Yeah. But the earliest visually significant glaucomatous visual field defect is paracentral scotoma. Okay, paracentral scotoma. Yes, Vinod, you're right. All right. Anterior chamber depth can be objectively measured by all except. Now, what is this anterior chamber? How do you define anterior chamber? If this is my cornea and this is my iris, from the posterior surface of cornea to the anterior surface of iris, that is anterior chamber. Yes. And what is the average anterior chamber depth? 2.5 millimeter, 2.5 millimeter. Okay, or a quarter of a centimeter. So 2.5 millimeter anterior chamber depth. Okay. So normally we shine the torch and say, okay, it's normal. Okay, so that comes with practice. Now my question is objectively. That means it's not subjective. Like I said, no, like I'm my favorite student. One of my favorite students is BU. We know. So when they say, I'm like very happy. Okay, it's very subjective. And you see ma'am's eyes glowing. And other people are thinking, oh, she's very subjective. You know, she's very subjective. It's not objective. So probably if they're writing theory exams, I'm usually not like that. Okay, let's say I'm also human. So if let's say we know this, my student and he's writing essay. So probably I'll give him 1 mark extra because he's attending all my YouTube sessions, right? So that is subjective. Objective is what he has written. If it's good, I'm marking for that. So anterior chamber depth not showing just torchlight and saying normal, deep, shallow. Objective. We're going to measure. Van Herrick method. So the question is objective all except. See, Van Herrick method is a slit lamp technique where we compare the peripheral corneal thickness with the anterior chamber depth. It's kind of a subjective assessment. Okay, kind of. Okay, let me explain the other options and you'll understand. ASOCT, anterior segment OCT is like you see it and you mark on the software and the software gives you from the posterior surface of cornea to the anterior surface of iris. So it is very, 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 very objective. Okay, it is very, very objective, right? The IOL master. See, IOL master is an optical biometry. It's an optical biometry. So that also gives you a perfect AC depth. Okay, it gives you that. Then ultrasound biomicroscopy, UBM. Yes, UBM also we can measure it very well, objective, because you're seeing the image and you mark on the image and you can measure. But Van Herrick is very subjective, because my mind, I look at it and say, oh, is it half? The ratio is half. I'm mentally calculating. Okay. So that time there is a little subjective element to it. So the answer here is Van Herrick. Yes, all the others are objective. Which are all the objective ways to measure AC depth? One, IOL master, that is your optical biometry. Anterior segment OCT, that is your ASOCT. Ultrasound biomicroscopy, that is UBM. Okay. All right. Now, let's go to the next question. Portable tonometer that uses prism. Portable means I can carry in my hand. It's very easy to handle. I can carry. That uses prisms. Tonometer. What is tonometer? Tonometer is an instrument to measure intraocular pressure, IOP. But I'll come, please put in your doubts. I'll clarify all your doubts after I finish all the question discussion. Okay. So please put in your doubts, type in your doubts, key in, I will check at the end. Okay. So portable tonometer. Option A, tono pen. Yes, tono pen is portable. Yes, it's like a pen. But does it use prism? No, it's not based on prism mechanism. So out. Perkins tonometer. Perkins' full name is Perkins handheld tonometer. Yes, yeah, you can. It's portable. You can take it into the OR. You can bring it out. Yes. And it uses prisms. Just like Goldman, it uses prisms, biprism, two prisms. Yes. So I think probably that is the answer. Option C, Goldman's tonometer. Guys, Goldman's tonometer is a small attachment to the slit lamp. Okay. It cannot be used without the slit lamp. And is slit lamp portable? Portable means, yes, I can shift it from one room to the other if I have coasters on the machine. If I put it on a table which has wheels with coasters, yes, I can push it, but that does not mean it is portable. Yeah. All right. I can't carry it in my pocket. No. So Goldman is out. It uses prisms, biprisms, but it is not portable. Schiot's tonometer. Schiot's tonometer does not use prism at all. It's totally different mechanism. All right. So the answer is Perkins handheld tonometer. It is a portable tonometer which uses prisms. Yes. Okay. Next question. Treatment of choice in acute primary angle closure, APAC. See, acute primary angle closure is the latest terminology or nomenclature for your acute congestive glaucoma, what we used to call ACG, or acute attack of angle closure. That is called nowadays as acute primary angle closure. So what is the treatment of choice? See, whenever this question about, see, the same condition, okay, either called acute congestive glaucoma or acute attack of angle closure or acute primary angle closure, APAC. Three questions are very, very important, not just as MCQ, even when you're managing the patient. What is the first thing that you will do? The first thing that you will do is you will decrease the intraocular pressure. Yes, because the pressure is way high. It's way high. It's 35, sometimes 70 millimeter mercury. Now you have to bring down the intraocular pressure very, very rapidly. Now don't think, ma'am, I'll put, a paracentesis. No, paracentesis here will not work, because I told you in CRAO, if you want to bring down intraocular pressure very rapidly, you can do paracentesis. But for putting a needle, you need a decent anterior chamber depth. But in acute angle closure glaucoma, the anterior chamber is very shallow. Sometimes it's almost nil. So you don't have space to put in the needle. You can damage the cornea or, the iris. Most commonly, you can damage the iris, the cornea. So no point of paracentesis out. Some drug with a rapid onset of action and which will decrease the intraocular pressure very, very rapidly. That is mannitol. That is the first choice, IV mannitol. If for some reason you're not able to give IV mannitol, like in my clinic, I don't have a bed, we don't have such things. So in that case, yes, you can give acetazolamide, oral acetazolamide. Or patient is not is a diabetic or has high renal problems, then you can't give mannitol, or has a congestive heart failure, you can't give mannitol, then give Acetazolamide. I mean, look at all the indications and contraindications. First choice, IV mannitol. Second, you can give acetazolamide. Then you can give some of the drops also. Okay, so you decrease the IUP. Yes, so first drug is preferably IV mannitol. Is that clear? To decrease the IUP. Second question is, now you abort the attack. Yes, I have to abort the attack. What do you give to abort the attack? The drug of choice. See, the attack was due to a mid-dilated or a fully dilated pupil, basically a dilated pupil. So to abort it, you have to cause constriction of the pupil. That means you have to induce meiosis. What is the meiotic drug? Pilocarpine. So give pilocarpine eye drops. Very good, BU. Yes, very good. Yes, so that is a drug of choice. Now coming to treatment of choice. Treatment of choice is, I have to treat this condition so that it doesn't occur again. That aborting the attack is a temporary thing. Okay, it's a temporary measure. Now I need to give a permanent solution to the patient, because most of the times these patients are hypermetropes, and every time there is a trigger that is causing this mid-dilated pupil, the patient is going to an attack and he cannot have this happening again and again. So you need to give this treatment of choice. Very good, Vinod, which is you make a small opening in the iris. Iridotomy. Otomy means opening. Iridotomy. Are we going to make it in the central iris or peripheral iris? Peripheral iris. Peripheral iridotomy. PI. And how are we going to do it? Using laser. Which laser? Something with just disruption. Padak. So that is a photodisruptive laser, ND-YAG laser. Yes, the same thing that we use for posterior capsulotomy for after cataract. Okay, so that is a treatment of choice. Now, please remember this treatment of choice. I will not only do it on the eye with the attack. I will also do it prophylactically on the other eye also, because this also must be hypermetrop. Most of the times patients are bilaterally hypermetrop. So you do it in both. Okay, so you do it in both, right? Okay, now that is a treatment of choice. Is that clear? So you know the first step, you know the drug of choice, you know the treatment of choice. Which of the following reduces episcleral venous pressure? See, episcleral venous pressure is the pressure in the episcleral veins into which your aqueous drains out. Okay, once it passes through the trabecular meshwork. So normal episcleral venous pressure is around 6 to 8 millimeter mercury. Now, which of the following drug reduces episcleral venous pressure? See, if you reduce the episcleral venous pressure, the aqueous will easily flow out. So one of the drugs, anti-glaucoma drugs, has this mechanism which reduces the episcleral venous pressure. Timolol? No. Timolol only decreases the aqueous production. Latanoprost increases the uveoscleral outflow. No. Netarsudil, yes, the Rho kinase inhibitors. The Rho kinase inhibitors decrease the episcleral venous pressure. Yes, although their primary mechanism of action is by decreasing aqueous production, they also their primary mechanism of action is increasing trabecular outflow. Okay, Rho kinase inhibitors, RHO, three mechanisms. They increase the trabecular outflow, they decrease the episcleral venous pressure, they also decrease aqueous production. Is that clear? Okay. Acetazolamide is a carbonic anhydrase inhibitor which acts by decreasing the aqueous production because it inhibits that enzyme which is involved in aqueous production. What is that enzyme involved? Carbonic anhydrase. Okay, next question. Which of the following drugs may cause secondary angle closure glaucoma? Secondary angle closure glaucoma. Option A, niacin. See, niacin is your vitamin B3 which is related to your macular edema. Nothing to do with glaucoma. Tamoxifen. See, tamoxifen can cause cornea verticillata, also known as your vortex keratopathy. It can cause toxic maculopathy. Okay, it can cause maculopathy, macular edema. Topiramate. I don't know. Let me see. Just like you, the same boat. Last option, rifabutin. See, rifabutin is one of those drugs which causes anterior uveitis, drug-induced uveitis, nothing to do with secondary angle closure glaucoma. Even if at all it causes glaucoma, because of the uveitis, it would be secondary open angle glaucoma. Okay. The secondary angle closure glaucoma is topiramate. Okay, topiramate. Now, any sulfa drug, topiramate is again a sulfa drug. So, sulfa drugs, they can cause ciliary body edema. Okay, ciliary body, when there is edema, what else will happen is, it will, I just told you, no? What's the cornea discussion, BU? Cornea discussion, I've discussed this completely. Okay, so ciliary body edema, when it happens, it will push the ciliary body forward. So when it pushes the ciliary body forward, the iris also will be pushed forward. The lens will be pushed forward, the iris will be pushed forward. So when the iris is pushed forward, what is in front of the iris? The cornea. Yes, so now the distance between the iris and the cornea or the anterior chamber is shallow. Is it because my iris is pushed forward? Is my angle narrowing, my anterior chamber shallowing? So do I have an angle closure glaucoma? Yes, I can get angle closure glaucoma in topiramate use, with topiramate use. So same way, which is that anti-glaucoma drug, which is a sulfa drug. So sometimes, a paradox, you give brinzolamide, dorzolamide, especially the topical ones, not astazolamide as such. So sometimes when the patient gets a sulfa reaction, yes, so he can get not a proper sulfa allergy, but still a ciliary body edema, can get secondary angle closure glaucoma even with carbonic anhydrase inhibitors. Okay, so this is very, very important for your Viva. If you're doing very well, they might ask you, my final year bache. All right, we'll move to the next question. Antimetabolite used in trabeculectomy. What is the antimetabolite used in trabeculectomy? Option A, paclitaxel. Nah. Mitomycin, yes. Fibrin, no. Bevacizumab, no. Mitomycin C we use in trabeculectomy. We apply on the scleral flap for a limited period of time and wash it away, just like how we used in pterygium, so that fibroblastic proliferation will not occur, resulting in failure of trabeculectomy. So this enhances the success of trabeculectomy. So we use mitomycin C. Okay, let me take a look at your doubts. UBM, no, Vinod, it is not used in corneal endothelial assessment. Corneal endothelial assessment, we typically use specular microscopy. We can also use confocal microscopy. Okay, UBM, no. UBM is basically for angle assessment. Okay, angle assessment when you want to look at ciliary body, especially when you have a limbal dermoid and you're looking for intraocular involvement of the limbal dermoid and all. In those cases, yes, but it's a little cumbersome procedure actually, UBM. Yeah. Okay. Very good. BU, Vinod, yes. Sad, I will explain this in, that would be very difficult to explain in this session on the HFA. I will add a video on the app. Okay, you can watch it on the app. Okay, Vinod has answered your question. All right. Yes, amiodarone is the most common cause of vortex keratopathy. All right. Okay. All my books are behind me. Some of my books are there. And my reading books are also there, which are hidden. Okay, so that is my rocks workbook. That's my handwritten. I think that's the, oh no, this is the OSM question answer book. And that little, I think this orange one. Yeah, this orange one is a handwritten rocks workbook. And that is the Josh Clinic Viva book. And we also have a fundus workbook. All right. You're most welcome, guys. So today we don't have a quiz, and tomorrow, I think tomorrow we have neuroophthalm quiz at 6 p.m. So today evening, 5 o'clock, we have fundus walk session. So I'll see you there. And 6 p.m. we have all the images that we did through the last 1 week on Instagram. So all that I will be discussing with you. So the images decoded session is at 6 p.m. So we've got a long day ahead still, but a lot of fun. So I'll see you at 5, bache. I hope this session was helpful for you. So Saad, I will definitely put up a video. You remind me on WhatsApp, okay? And guys, you can join the test and discussion. So we have 3 batches, one for NEETPG, one for INICET up to May, and then we also have a PDCET batch. So I will also give the link to it in the comment section. If you want to join, you can join. All right, and you can take a free look at the test and then decide if you want to join. So you can let us know. We'll give you free access and then you can decide. Okay. So bye. I'll see you at 5. Have a good Sunday, all of you. Take care of yourself. Hey, thank you so much, beta. Lovely. Please pray for me so this neck becomes okay. I just want to take off this collar. It's it's so constraining, a lot of constraints. Okay, yeah, I am fine. Otherwise, all right. Okay, guys, I'll see you at 5. All right, ciao.